These are two sensors. One is on the robotic arm and one is in the robotic unit. These two are sensor. This is an camera is in optimal position. Well, next the step, we have to focus on the confirm lesion center on the Navy tracker ER. Next, we have to log all the camera position. Now there are 6 registration point. We have to press the pedal to registration of ROSA. The robotic arm is deciding the area of work. This is an 6th point. Then this is the 5th point. That is registering the ROSA, the workflow. There must not be any hurdles in between. It is deciding its area. After all registration, like we have to perform the incision, we have to midline incision, skin, soft tissue dissection, then we have to reach up to the bone by medial vastus, subvastus or medial parapatellar incision. After the incision proper exposure, we have to insert 2 femur shank pins. The shank pins are around 3.5 mm thickness. One, and parallel to that we have to insert another shank pin. We have to just bicortical the femur shaft, not the fully cross the both the field. Then we have to fix the femoral sensor by the screw. This is an femur sensor. As femur sensor is inserted, we have to insert the tibia sensor on the shaft tibia. This is an also 3.5 mm of drill, and we have to just pierce a third cortex, not the fourth cortex. After the proper positioning of the femur and the tibia sensor, this is a tibia sensor, this is a right side and left side specific, and the robotic arm specific. Then we have to fix this tibia sensor by the screwdriver. Yes, both are the sensor, honeycomb sensor that will capture by the unit. After the proper exposure, after the proper ossified release, medial release, post-medial release, then we have to shift to the robot. In the first evaluation of the femoral head, there are 14 points of femoral head center that we have to register by a rotation method. We have to rotate the femur in the proper circle manner. All the point is registered by the optical arm unit. There are 14 rotational point of the shaft head of the femur. Then this is an pointer sensor that we have to point all the registered point. First is the femoral axis. Then this is an posterior condylar sensor outlet. It is also a specific right and left side. For that we have to insert in the posterior condyle, and then we have to measure all the rotation, flexion, extension. Then it is captured by the optical arm. Then we have to point the anterior trochlear groove. Then we have to fill the posterior trochlear groove. Then we have to fix the medial epicondyle. Then we have to distal femur medial condyle. There are 3 registration points. in that don't pierce the remaining cartilage. You have to just touch the rotation, then the lateral femoral condyle, then the lateral distal condyle. There are 3 registration points in the lateral distal condyle, and there are 3 anterior cortex to prevent the notching. And the femur, the rotation and all the point is registered. Now we have to jump to the tibial part. For that, the medial malleoli, first lateral malleoli, that is not possible on the bone model. Then the medial third tubercle, then the tibial axis point, then the PCL insertion point, then the medial tibia plateau. Again, don't pierce the remaining cartilage. This is the lateral patellar tibia plateau. After all the registering the point, like we have to evaluate the movement and the ligament status and the flexion extension varus valgus. For that, like on table, we can evaluate the things, all the ligament status and all the things. The movement of the tibia, movement of the femur, loosening of the femur, what are the parts of osteophytes, medial laxity, how varus, how extension, hyperextension or the FFD, all the movement measured in the portion of the evaluation during the tibia. After that, all the evaluation, we can save the data. After that, they ask about the exposures of tissue release or osteophyte removed or yes. If you remove it, then we can proceed with the yes. Then there is a slide. On that we have to calculate the things, femur rotation, on extension, on flexion, then the flexion. If there is a notching, then you can stylus the height and you can even change the slope, whatever you want to do. You can even change the flexion. There is a 3D reflection on height. You can the varus and valgus, all the calculation you can do here. Whatever the things, whatever the cut you want, whatever the measurement you want, whatever the rotation you want, all the things you can do here. You can even upside the femur, downside the femur. Then you can go to the balance. In the balance, there is a gap of 19 mm that you have to recover of that thing. For that, you can decrease the tibia, even the rotation of that thing. Then there is a you can change the femur rotation, all the things. After all the calculation, you can go up to the resection plan. Then resection plan, in that resection plans, there is a chat point. For that, you have to change the after the all the calculation. When you go for a resection, there is a kind of a zik that is implant specific and the side specific. If you operating the left side, then the right side there are 2 zik. This is an persona zik that useful for persona implant only. There are 2 to 3 joint. We can proceed with this. Then there is a check point that you have to check the things, whether you install a proper zik or not. The checkpoint is required. After the confirmation by the checkpoint, then you proceed with the resection guide. In that, there is a distal femur cut. Like in that, you have to press the pedal and the robotic arm exactly come to the area of the distal femur and the distal femur cut. After the green signal by the collaboration mode, you can very well come to the near to the bone, and this is so precise that if you move your femur then even the micro motion on the robotic arm also. So the robotic arm will never change, it's plain. So you can very well cut with that distal femur cut. There is a live value on that the flexion, extension, what you are going to cut and all the things. After performing the distal femur cut, then if you are happy with the cut, you have to remove the pin, you have to disengage the robotic arm, and then proceed with the other cut. Then you can validate the femur and tibia. After the all the things, you can go to the tibia cut, distal femur cut, then you have to go for a tibia cut. Then robotic arm exactly come to the tibia very well, with well aligned, with well accuracy, with all the measurement. After the green signal by the robotic, you can very well put to the things, and you can put pin here, and you can cut the tibia by with measurement that you are planning. And after the all cut, you can remove the pin. After removing the pin, you can validate the things, all the validation. After validation, you can disengage the zig, and after disengaging the zig, you can proceed with the 4-in-1 things. 4-in-1 resection. For 4-in-1 resection, after distal femur, proximal tibia cut, and then you proceed with the 4-in-1 zig. That is exactly come to the point where we plan the things, and you can very well proceed with this cut. You have to insert the pin, you have to see the monitor, you have to see the live value. All the live value accepted, then you can cut the femur. All the things are there. When pin removed, you can very well disengage the things. After disengaging, you can ROSA to be home position. After the home position, we can, after the home position to the ROSA, we can, after the implantation, femur implant, tibia implant, and the insert, after the final implantation with your metal things, you can evaluate the things very much what are the flexion you can achieve on table, and then what are the extension you can achieve, what are the HK axis, what are the varus valgus, flexion is 0.5, and then the varus is around 3 degrees, 6 degrees, 0 degree. Very well, the flexion is measurement, and the on table movement you can very well. After the final implantation, you just all the movement is registered on that thing. Then you have to remove this both the sensor is removed with the help of a screwdriver. And you can very well remove the pins. There is no any other hazardous complication regarding the pin thing. And the surgery is over. Thank you.